Very important webinar. This year's theme is closing the gap. And for us, closing the gap is to provide breastfeeding support for all women giving birth in maternity hospitals in India, both in public and private sector. In public and private maternity hospitals. I welcome you all. Thank you for joining us here in this important webinar. And today we are going to, here is the agenda of the webinar. We are going to discuss how we can universalize education on breastfeeding during pregnancy. And Dr. Jaideep Tank, who is currently the president of FOGSI, is going to address us on this occasion. Followed by that, we'll have a talk on comprehensive lactation management for optimizing mother's own milk banking, its usage in NICU by Dr. Sushma Nangia, President NNF. Followed by that, we will have a presentation on closing the gap in a military hospital by Colonel Subhash Chandra Shaw, who is the Senior Advisor Pediatrics and Neonatology at the Army Hospital, RNR, New Delhi. Post this, I'm going to share the tools that we have developed to close this gap that we are offering to everyone, whosoever is interested, to take them up and become breastfeeding friendly. Post that, we have Dr. MMA Faridi, who is the Dean of Era Medical College. He will share his experience of implementing the MA program and 10 steps in a private medical college hospital in Uttar Pradesh, followed by question and answers by all the participants and a summary of way forward on this theme by Dr. Arun Gupta, who's the Central Coordinator of BPNI. So I welcome you all, and we can begin this webinar with I'll first invite Dr. Jaideep Tank, who is an obstetrician and gynecologist and an IVF consultant. He's currently the president of FOGSI. Sir, you're welcome. Over to you. Rima, you can stop sharing this.
Yeah, I don't think there's any share. Thank you very much.
Yeah, Rima, you can stop sharing the program. Yeah. Over to you, sir.
Okay. I hope I'm audible.
Yes, absolutely.
Yeah. So thank you very much to BPNI for organizing this important webinar during the World Breastfeeding Week. And I think the topic of the webinar, which is closing the gap by breastfeeding support for all women giving birth, is perhaps most appropriate because, in fact, it is the support that can be given to all women and persons for breastfeeding, which would really mean success for making sure that every neonate gets breast milk, which is, of course, as we know, the best source of nutrition for the neonate and the child. I'm very grateful to Dr. Arun Gupta for all the hard work that is being put into making this a reality, along with the colleagues from BPNI, and of course, Dr. Nupur, Dr. Sushma from NNF, Colonel Subhash Chandra Shaw, Dr. Faridi, and all of you who have taken time out to participate in this webinar. I do hope that all of you know what FOGSI is, but in case you don't know what it is the Federation of Obstetrics and Gynecological Societies of India. We are an association of professionals consisting of around 43,000 members across India, with around 275 local societies. In fact, if I cast my mind back, it is actually quite a moment for me to remember that FOGSI started having annual themes in the year 1997 to 98, when my father was the president of FOGSI. And in fact, the first ever annual theme of FOGSI was on breastfeeding, where a lot of activities were done in the year to promote, increase uptake, and make breastfeeding easier for the mothers and their children who have delivered. Since then, of course, FOGSI has had an unwavering commitment to make sure that every person and woman who gives birth is able to make sure that the neonate gets the best source of nutrition, which is breast milk. There are, however, still significant gaps in the number of mothers who are able to successfully breastfeed to their satisfaction. And you have to wonder why this is so. After all, if you consider the fact that our popular culture has got so many references to breastfeeding with, the "maa ka doodh piya hai" kind of dialogues, which are so, so prevalent in our movies with titles like "Doodh ka Qarz" and so on and so forth. Uh, there is this whole question as to why something that is popular in culture does not get translated to reality. It is something which has often given me pause, and perhaps we need to approach it from the four kind of um, silos, or I won't say silos because silos would actually mean that we are siloing it, but that's not the intent of using that word, but perhaps from four different aspects. And for me, those aspects are stories, stigma, decisions, and support. And let me start with the first one, which is stories. Uh, we strongly believe in the power of stories. We strongly believe in the power of stories, not only for education, but also for inspiring. We also think that perhaps we don't share enough of our success stories. We always share stories of our hurdles. And perhaps it is high time that we start sharing the stories of our successes. And when I say start sharing the stories of our successes, I don't mean in a purely scientific way to our colleagues. We need to start sharing stories of success in terms of how women are able to breastfeed with other women, with the community, and make this a community facing effort which is much more prevalent and much more easily available. Which leads me to the second part of the thing, which is stigma. I don't think there is any doubt that for some reason, if a woman says that she perhaps does not have enough milk, and honestly, this, if you, I would have had the video, you'd have seen that I'm using quotation marks around the words enough milk. It does cause a lot of stigma. It affects mental health, and it also leads to the woman losing confidence in herself for her ability to feed. I've always felt that this is a woman who needs a lot of support. And this support has to be delivered in a non judgmental way, without increasing stigma and without attributing a sense of failure to that woman who is already maybe exhausted after giving birth and so on and so forth. And lastly, I'd just like to talk about the very large number of decisions that women make through the course of pregnancy and the process of birthing. We underestimate how many decisions go into each pregnancy, and let's say in terms of where to give birth, which supplements to take, am I doing the right thing by way of my pregnancy, in the entire process of birthing. And by the time the woman finally gives birth, we must consider the fact that perhaps she is a little tired of making decisions. And it is at that point that muscle memory kicks in. And if we make enough of an effort to educate, inform, and make her capable in a way, not in a condescending way, but capable in a way of breastfeeding with ease, we will reduce the number of decisions that she has to take and therefore increase the uptake of breastfeeding. I would just like to again say in the end that FOGSI, its members, obstetricians, and gynecologists are fully committed to the cause of breastfeeding. And we hope that we see a day when what is perceived as natural actually becomes reality. Thank you very much.
Thank you, Dr. Jaydeep Tank, for this important address and the message that you gave in the last, that what is perceived in culture should become a practice also. Thank you for your encouraging words. Now I would invite Dr. Sushma Nangia for her topic on Comprehensive Lactation Management Center, CLMC, for optimizing mother's own milk banking usage in NICU. Dr. Sushma Nangia is MD in Pediatrics, DM in Neonatology, and is currently the Director, Professor, and Head Neonatology of Kalavati Saran Children's Hospital and LHMC, New Delhi. She's the convener of National Collaborative Center for Facility-Based Newborn Care of Ministry of Health and Family Welfare, Government of India, and also the convener of National Comprehensive Lactation Management Center, Vatsalya Matri Amrit Kosh. She has 242 publications in various journals and books to her credit. And she's also a member of National Technical Advisory Group on Facility-Based Newborn Care of MOHFW, Government of India. Welcome, ma'am, over to you.
And Nupur, can you ask if somebody has a burning question before Dr. Tank has to leave? I think.
Okay. I saw one hand raised.
I think he has already. I think he has already left. I think Dr. Tank.
Tank has left.
Okay. Okay. Go ahead. Welcome, Sushma ji. Thank you so much for joining, and please.
Yeah. So, Sushma, you may share your screen.
Yeah, I'm sharing the screen. Thank you, BPNI. Thank you, Arun Gupta sir. Thank you, Nupur, for this opportunity. And I'm so glad to be a part of this. It's an honor as well as privilege that I will be talking about the comprehensive lactation management centers for optimizing mother's own milk usage in NICU. So as the president of National Neonatology Forum, as well as being a clinician and running a comprehensive lactation management center, most people would understand that CLMC or milk bank is for donor milk. But what I'm here to burst the myth or share with you is that CLMC is actually for optimizing mother's own milk for use in the NICU, and that is what is the best for her baby, the biologic mother's milk, what we call as the mother's own milk. So let me just take you through. This was on the 7th of June 2017 that our milk bank was opened, and we had called it National Human Milk Bank. The Secretary Health from the Ministry, Government of India, was there for the inauguration along with the Norwegian ambassador, who, because this was with the help of Norwegian government support that we opened it. But very soon, 2 months later, we had to name it as CLMC, Comprehensive Lactation Management Center, because we had our national guidelines for human milk banking come in 2 months later in August 17. And these national guidelines on lactation management centers for public health facilities advise that we have comprehensive lactation management centers at medical colleges which have NICUs or large district hospitals which have SNCUs. Lactation management centers at district hospital, large subdivisional hospitals which have functional SNCU, and lactation support unit at every delivery point. And what are the functions of that? So this LSU has to be at every birthing place, whether it is an maternity OT of a tertiary care hospital or it's a subcenter, a labor room and a subcenter. So the function is lactation counseling and breastfeeding initiation for the babies born there. When you look at 2, 3, 4, and 6, which is with the LMC, so LMC, the Lactation Management Center, has to take the action of stimulation and expression support through electric breast pump or even manually, collect donor milk, store donor milk, and dispensed donor milk received from the CLMC. So CLMC is supposed to be processing the donor milk, which is what we know as pasteurization. So we need to have one CLMC with a few LMCs around so that this works in a hub and spoke model, and this is the functioning. So the LMCs can actually collect milk, the milk that is surplus more than what the baby requires, the biologic baby requires. So if the mother is producing more milk, that can be voluntarily donated. So this can be stored. It can be sent to CLMC where it is pasteurized and returned back to the LMC for use for small and vulnerable babies in their own setup, in their SNC. So what is the role of CLMC for small and sick neonates as regards lactation management? Well, meticulous counseling and motivation of mothers of the babies who are in NICU, pumping support as required, both for stimulation and for expression of milk, and then establishment of milk kitchens in the NICU for donor milk or pasteurized donor human milk disbursement, because this cannot be just done very casually. All through, asepsis has to be maintained thoroughly so that the babies receive milk in an aseptic manner and they are not exposed to additional infections. So the role of CLMCs are lactation management centers are in no way intended to lessen the importance of mother's own milk or the practice of breastfeeding. These centers are for reinforcement, for protecting, promoting, and supporting breastfeeding. And as an extension, these CLMCs would cover for babies who are not getting the benefit of breastfeeding due to unavoidable reasons by providing them pasteurized milk. So pasteurized milk is really to support the small and sick till their mothers can produce enough milk. It is just as a bridge support. It's not something that eliminates or that is instead of mother's own milk. So the ultimate goal is to promote breastfeeding even for the small and sick babies, initially express milk and eventually feeding at the breast. So talking about PDHM for a minute, we all know that human milk is undisputed gold standard and mother's own milk is far better than pasteurized donor milk. With increasing milk bank establishment, all of us must focus, and our focus should be on increasing the provision of mom for the biologic baby rather than donor milk substituting its inconsistent availability. PDHM is mainly for babies who are less than 32 weeks gestation and for a maximum period of 2 weeks, first 2 weeks in their life. So whenever we get requisitions or people want it for a post-cesarean baby, a full-term baby, a 34-weeker, it's really not required. So PDHM usage should be minimal. In our setup, for example, it hovers around 5% of the daily requirement of milk for the whole unit. So it should not be replacing mother's own milk. It should not be viewed as something equal to mom and it is replacing formula, but there is no mom being given, it's all donor milk. And for that, what we need to do is ensure that there is appropriate antenatal counseling. You can see our counselors promoting, protecting, supporting breastfeeding. So they are there with props, with some of the charts, explaining to mothers in the antenatal clinic. See also here, the props here, and these are the mothers in the antenatal clinic. Some would be grandmothers as well. So who are being explained about breast milk and breastfeeding by our counselors. Then counseling in the maternity ward. There are many mothers who have their baby with them in the postnatal ward, but there are mothers whose babies are in the NICU. So again, trying to explain to them all about breastfeeding. The crucial aspect, which is the third one after antenatal counseling, postnatal ward counseling, is pumping support to the mothers whose babies are in the NICU. You can see the mothers being supported by pumping. And now whatever she pumps out, this is for pumping support to NICU baby's mother for providing mother's own milk to her small and sick baby, the biologic baby. If there is surplus milk, only that is to be donated, that too voluntarily by the mother. If she doesn't want to donate, should be no coercion. There should be nothing to say that, yes, she should be donating it. So this is the express milk, hand express, and this is the one that is pumped out, labeled for the biologic baby and even the prenatal unit. And this was awarded at the IRSHML meeting at Japan. This was also presented at the PAS meeting at Maryland, USA. We went through 5 PDSA cycles, and you can see the mother's own milk usage in the unit. Mom increased from 44% to 61% at the end of first PDSA, 66%, 69%, 71%, and nearly 75% by the end of the 5 PDSA cycles over 8 weeks. So you see here the mom increment in the unit, and you see here the decrement of formula, and you also see the donor milk usage in the unit hovering at around 5%, 6%, because only babies less than 32 weeks, only for the initial 2 weeks. Rest of the babies, while we are trying to get mother's own milk, can be fed something else. And this has been possible because of closed loop communication between the two NICUs and the milk bank team. So the resident posts, these are the mothers. In this maternity ward, we have 9 maternity wards. And please follow these mothers. This one is in MAT 5, this was in MAT 8, and so on. And 10:52, it has been posted by the resident. And from the milk bank by 11:48, less than an hour, all mothers have been followed. So-and-so is not in the bed. Phone number is not reachable. So that much is the focus on the mothers of NICU babies, the closed loop communication between the NICU and the milk bank team. So my take home would be mother's own milk is the best feed for the baby, including for the sick and small. If mom is insufficient or not available for any reason, PDHM or formula is the next best alternative to bridge that gap. CLMCs and bridging gap is also our theme for this year. CLMC's main function is to promote, protect, and preserve breastfeeding for healthy babies and mom feedings for the NICU babies. Milk donation by mother to a CLMC is a voluntary activity. Human milk banking is a highly skilled activity involving precision along with asepsis in the collection of milk, in the storage of milk, in the processing, which is pasteurization, in handling the milk post-pasteurization, and disbursement to the NICU. So donor milk should be used just as a short-term life-saving alternative and not as a replacement for mom. I think that's all that I have as regards CLMCs working towards provision of mom for the baby in the NICU. Thank you so much. I'll stop sharing my screen and I'll be happy if there are any questions to be taken.
Thank you, Dr. Sushma, for this wonderful presentation. Even I have learned a lot after your presentation because there are always, some questions and clarification which people need. I'm sure there would be questions. We can address them in the end. Now, in the interest of time, I would like to invite Colonel Subhash Chandra Shaw for the next presentation on closing the gap in military hospitals. Dr. Subhash Chandra Shaw is a professor of pediatrics and a neonatologist at Army Hospital Research and Referral, New Delhi. He's a MD and DNB in pediatrics from AFMC and DM neonatology from AIMS, New Delhi, and FAIMER from SATE GS Medical College, Mumbai. He has served as a professor in pediatrics and neonatologist at Armed Forces Medical College, Pune. He's also the associate editor of Medical Journal Armed Forces India and Journal of Neonatology. He's a member of NNF Committee on Breastfeeding, and he has been awarded with the Chief of Naval Staff Award for Best Published Paper in 2023. Over to you, Dr. Shah.
Thank you so much, ma'am. Are my slides visible?
Yes.
Thank you so much, and good afternoon all. I'll be dealing with closing the gap in our setting, that is in a military hospital setting. So just some basic statistics, like what we know as per NFHS 5, National Family Health Survey. 5 is that children under age at 3 years, that is being breastfed within first hour of birth, is at 41.8%. And by 6 months, exclusive breastfeeding rate is just 63.7%. And children aged 6 to 8 months receiving solid or semi-solid food and breast milk is at 45.9%. So far away from ideal. Now let's try to understand what is the problem and why this gap needs to be closed. Now look at this slide. So from NFHS 1 to NFHS 5, the institutional deliveries have gone from 26% to 88.6%. But the early exclusive breastfeeding, that has not risen. It has just risen from 41.6 in last NFHS 4 to 41.8 only. So you can see the gap. The gap is really a long gap that we need to conquer. So another point that we need to know is that even in initiation of breastfeeding, there's a problem. Are we feeding our babies in the first hour of birth? The percentage is just 41.8%, whereas feeding in the first day of life is 86.8%. What does it mean? That means half of the babies who should have been fed in the first hour of birth are not being fed. Now, if we talk about the breastfeeding statistics over the months, so we see that at 2 months, it has come down to 75.7%, and by 4 to 5 months, it has gone to 48.9%. So again, the problem is that neither are we feeding at the first hour of life, nor are we feeding continuously till 6 months or beyond. So where is the problem? Probably the solution also lies in these 10 steps, and if we follow these 10 steps carefully, then we should be able to close this gap. So we know these 10 steps already, but still just to have a context, is that right from hospital policy. So now in these slides, I'll try to explain what we do differently in our setup. So we try to follow all these 10 steps very rigorously and as true as we can. So in our hospital policy, there is no promotion of infant formula, bottles or teats. We make sure that there is a policy, every hospital, there's an SOP there, and it is being followed. For staff competency, we have regular classes for our nursing officers and also for the mothers, both antenatal and postnatal. In antenatal care, this is a routine practice for us to talk about breastfeeding, and also right after birth. That is, as soon as the baby is born, even before the placenta is out, the babies are taken to the mother and babies are kept skin to skin soon after birth, and breastfeeding is started there only. And then supporting of mothers does not only remains in the labor room itself. It has to be done beyond labor room also, or beyond the delivery room. So this support is continued with the help of the nursing officers, the pediatricians, and lactation counselors, which are now there in many of our military hospitals, and they are giving continuous 24/7 support. As far as the supplementing is concerned, that is, in case a mother is not producing enough milk, as Sushma Nange ma'am also said, in the first few days of life, that too in less than 32 weeks. So in that case, we try to get milk from other mothers, and already human milk bank is there in Command Hospital, one of our biggest hospitals, and in other hospitals also, it's in the pipeline. Very soon we are trying to get breast milk, human milk bank in most of our zonal and Command hospitals. Regarding rooming in, it's not even rooming in, it's bedding in, and we follow strict rooming in with the mothers. And what we follow is responsive feeding. It's not like 2-hourly feeding or 3-hourly feeding. Whenever baby asks for it, there are feeding cues, and I'll show in one of the slides that we follow in all our hospitals. Regarding the bottles, teats, and pacifiers, they're absolutely not encouraged in any of the postnatal wards. And the babies are discharged only and only if mother is comfortable and competent in feeding their babies. Till it is done, their discharge is generally stopped and they are not sent home. Now, coming to some more things that we have done in our setup is that this education and awareness about breastfeeding, this actually started from the beginning of training of every health worker. We have in our Armed Forces Medical College, there even at UC level, there are hands-on workshops, seminars, dedicated classes and clinics. They are being held there. Then the other kind of things that we do very routinely is that, as I said, in the first few attempts to breastfeed, we are there with the mother. So this hand-holding of the mother is very, very important. And each time the proper positioning and attachment has to be shown to the mothers that we routinely do. The babies are never separated from the mother unless baby is premature or sick enough, or mother is sick, mother has gone on ventilator or gone to ICU. Then only mother and babies are separated. Otherwise, they are not separated. Babies are fed mother's milk only, and they are roomed in even in cesarean section deliveries, and even all cesarean section deliveries. The attempt is done to feed every baby at the OT table itself. And then, as I said, they are never discharged before 48 hours, and they will not be discharged till breastfeeding is established. At no point, formula feeding will be introduced unless medically indicated. Then, as I said, SOP in every hospital is in place, which is rigorously followed. And by now, most of our hospitals have got lactation counselors, and they are working there round the clock. mother is never discharged, leaving the preterm and sick infant in NICU. This is also a little bit unique thing in our hospitals, that, you know, unlike some corporate hospitals where mothers are sent home and they come for expressing milk and then again they go back, in our hospitals, everywhere mother will remain admitted till the babies are there in NICU. And this helps us a lot in getting mother's milk, and also mothers are more comfortable with their babies. And no formula milk feeding unless medically indicated, even in NICUs. We'll always try to feed mother's own milk only. And if not, donor mother's milk, but not formula milk. And there will always be an arrangement for the expression of breast milk by the mother, and its storage is available, including availability of breast pumps. So much so that manual breast pumps are provided free of cost in few of our hospitals, including Army Hospital, RNR. They are not like mothers don't have to buy breast pumps, the manual breast pumps that we get for each mother. Now, some other interventions that we have done and has been successful is that display of IC on breastfeeding at prominent places, MI rooms, that is what we call emergency rooms, we call MI rooms, and family welfare centers. Then breastfeeding room is there in every OPD and available to support for breastfeeding 24/7. Even at night or any time a baby comes, they will be taken to pediatric ward, and the resident over there or the nursing officer will help the mother in breastfeeding. There will be efforts always to create breast milk banks in all hospitals with substantial neonatal load. As I said, there are some 17 hospitals are there which are very soon going to get human milk banks. And then there will be celebration of breastfeeding week that is being done in last 7 days at every hospital, including quiz, poster making, health education of antenatal mothers and postnatal wards. This is routine for now, decades, in last few decades. Coming to standard operating procedure, this is a typical SOP that we have in our setups, and this is from my own hospital. And there, every recommendation is written, and it is, it has to be followed by everybody. Then these breastfeeding promotion posters are everywhere in every hospital there, in the MI rooms, the OPDs, the wards, labor room, the OT, everywhere. The breastfeeding cues, we always follow this responsive feeding, and it is always on the basis of breastfeeding cues and not on the basis of timely feeding. This helps a lot in establishing, breastfeeding early. Then these are some pictures that is routinely being done. These are not from breastfeeding week. These were earlier done, like this education that is being done for postnatal mothers, as well as the third photograph that is on the antenatal mothers. Even twin babies, they are being fed by football position. So all these things are being done at all our hospitals. Then we have also done some quality improvement projects that has helped us in, bringing back exclusive breastfeeding in hospitals where there was a problem. And those approaches of PDSA cycles and, place people, policy and procedure, we go through, each hospital goes through like the problems that we are facing, and we try to solve them. Then there are many research papers that we have brought out, like this knowledge of breastfeeding practices in doctors and nurses. We were like initially when we started our journey, then we found that at many points you find that your own doctors and nursing officers are not well versed at what to be done. So it is a good idea to know your knowledge base of your own doctors and nurses, because if they themselves are not well versed, they will not be able to counsel the mothers. And then you try to improve exclusive breastfeeding rate in the first 24 hours of life by doing these QI projects. Today, we are proud to say that many of our hospitals are BFHI accredited, and it started from Command Hospital, Southern Command, Pune, that happened about 2 years back. Then our own hospital, my hospital, Army Hospital, and then Jaipur, Kamti, that is near Nagpur, Gorakhpur, Chennai, Mumbai, Panchkula, Chandigarh, Udhampur, Lucknow. All these hospitals are accredited today. And we feel very proud to say so, and also we continue our, as for improvement as you can do in breastfeeding rates. So these are some of the steps that we have taken, the interventions that we have done, which have helped us in bringing back exclusive breastfeeding rate to the highest possible that we can do. Thank you so much.
Thank you, Colonel Shaw. You can switch on your camera now.
Okay.
We have overcome the technical glitch. So
okay,
that
yeah, I was not aware that I can.
Yeah, thank you for such brilliant presentation.
Great to see every one of you. So
Yes,
happy and smart.
finally.
Thank you. Finally.
We can actually click a picture quickly. Dr. Shushma, you can also switch on your camera, ma'am. Dr. Sushma, can you hear me? Okay, thank you. Okay, smile. All right. Thank you. Thank you. So moving on with the program. So there are some questions directed to Dr. Sushma. We can take them in the end. We are just about to finish. It's our last two sessions that are left. The next one is by me on the tools to close the gaps, the tools that BPNI offer. I'll share my screen with you all.
Nupur, do you want me to answer them online, or we can do that later? As a
Ma'am,
question?
if you wish to answer them online, you may. And then maybe in the end, if we have more, we can address them then.
Thank you.
Yeah. I hope my presentation is visible to
Yeah.
everyone.
Yes.
Yes.
Okay. So my presentation is about the tools that BPNI is offering to close the gap and to become breastfeeding friendly. This year's theme, as we know, it's about closing the gap, and we are urging all maternity hospitals, whether public or private, to become breastfeeding friendly and support all women giving birth there. There are 7 tools that BPNI is offering to all the public and private hospital administrators, gynecologists, pediatrician, whosoever is interested to become breastfeeding friendly. So the number one tool is a model breastfeeding policy. And all these tools also facilitate the observance of WHO 10 steps as well. So in every slide, you will see that each of the tool is contributing to implement one of the WHO steps in a maternity hospital. So we provide a model breastfeeding policy. It is all these tools are available on our website. The idea to have a breastfeeding model breastfeeding policy to foster a supportive environment, ensuring that there's consistency, there's high quality of care and guidance to all mothers who are delivering in maternity hospitals. Hospitals can use this model breastfeeding policy, and they can customize this with their own names. And it helps in implementing the WHO step 1B of having a written policy at the hospital. The next tool is about antenatal breastfeeding education. It's an initiative by BPNI called I Decide, where we facilitate the feeding decision of pregnant women. We start talking about their breastfeeding decision and feeding decision during pregnancy itself. It is a digital and education platform. It's a website where women can go and register themselves and access these 6 to 7 modules that are present there. They address various themes from initiation of breastfeeding within first hour of birth, skin to skin contact, safe preparation and handling and storage of infant formula if a mother decides to do so for any medical reason, and many other informative modules. So we are planning to introduce this. We have introduced this to the pregnant women and their husbands and their family. They can go log in and freely access all this. And we encourage all the hospitals who register with us or are interested to go and share this with their pregnant mothers during antenatal period. This particular tool helps to implement WHO step 3, where it is suggested to discuss the importance and management of breastfeeding with pregnant mothers. The third tool is about monitoring breastfeeding data in maternity hospitals. It is an Excel-based tool that we have created, and it is used to monitor breastfeeding data in hospitals systematically. It analyzes, it reports. It helps hospital to check their trends if they start using this Excel tool. It can be downloaded. The link is given below. It is on our website also. And it will support hospitals in implementing WHO's step 1C that asks for establishing ongoing monitoring and data management system. Tool 4 is it's a checklist of 18 indicators to monitor the breastfeeding program. And if you need more information, you can write to us about it. And this particular tool would help you to establish step 1C of establishing ongoing monitoring and data management system. So these are the 18 indicators that a hospital must check on if they want to become breastfeeding friendly. The next is our training course. We have specially curated this training course for hospital staff, for maternity hospitals, so that they can get equipped with skill training and they can effectively implement WHO stencil. They can effectively help mothers to practically breastfeed, and it helps implementing the step 2, 5, 6, 7, and 8, and 9 of WHO, and all these steps were also discussed in Colonel Shaw's presentation as well. Then we have another course, skill training course for ANM and other community workers also. And it helps in observing and implementing step 10 of coordinating discharge so that the parents and infants are supported after discharge also to establish exclusive breastfeeding. The last and the 7 tools, we have an information sheet on the implementation of IMS Act and what constitute a violation in IMS Act. We also have a presentation which is freely available to download, and hospitals may use it in their hospitals to educate their staff on various provisions of IMS Act. And it helps in implementing WHO steps A1, where it is asked to fully comply with the international code. And as we know, that IMS Act anchors the international code in India. So we are happy to assist both public and private hospitals in becoming breastfeeding friendly. And you may write to us if there are any hospital management people or hospital administrators who are attending this webinar. You can write to us, and all these tools are available on our website freely, and you can download them. Apart from the training modules, the 2 training modules, we can share them on demand, and there is a nominal fees attached to it. And if you're interested, you can write to us about them. Thank you. Okay, so moving on with the program, the next presentation is by Dr. MMA Faridi, who's the Dean of Era Medical College, Lucknow. And he's going to share his experience of implementing MA program and 10 steps in a private hospital in his medical college. Dr. MMA Faridi has advanced training in neonatology from University of Illinois, Chicago, USA. And he's the Dean Emeritus Faculty of Medicine at Era University, Lucknow. He's decorated with the State Award by Government of NCT of Delhi. Dr. Faridi has worked as a director, professor, and head of Department of Pediatrics and IEC Division of Neonatology at University College of Medical Sciences and GTB Hospital, Delhi. He has more than 43 years of teaching and training and clinical experience in the reputed institutions in India and Nepal. And Dr. Faridi is associated with BPNI for more than 25 years now, and he has been a part of the curriculum committee, which designed and developed the 4-in-1 IYCF counseling training course on breastfeeding, complementary feeding, infant feeding, and HIV, and growth monitoring. Over to you, sir.
Thank you, Dr. Nupur. Thank you so much. And good afternoon, all the friends here. A wonderful talk by Sushma. I have present question also to her. And also, Shaw, I could see that you were able to implement BFHI in almost all army hospitals. I've got about 11 faculty members from army background. My medical superintendent is actually Brigadier Basu. He's a plastic surgeon. He was from in Lucknow only. Well, so when I joined this place, Era University, a usual thing which you will find in all the hospitals across, whether it's private or government. So decided to gradually increasing and discussing issues with the OBG people and our own Department of Pediatrics to ultimately come across and start following the guidelines of the BFHI. So I'll show some of the recently we tried to get it accredited, and then I went into the self-assessment, and I found there's a lot of gaps in self-assessment. So I hold on for a moment. I say I will not go for accreditation. That's the first fill up these gaps which are already present in our place. So we are being able to do, and one of the biggest was the training of the medical and the nursing staff. So I request Nupur to kindly show. I just summarize the whole thing in my 2-3 slides. So can I have the first slide, Nupur? So there I actually discussed the whole thing with the highest management people, including the chancellor of the university and also the trustee of the ERA Education Trust. And can I have the next slide? So here, what I could found that the strengths were there to be able to implement the MA and the 10 steps. So the strength of a private medical institution, which I could see, is that all the people want to get the university in NAC accredited, because this is the order of the government of Honorable the Governor of Uttar Pradesh. All the universities in UP should be NAC accredited. Hospitals should be NABH accredited, because otherwise the CGHS and other clients will not come to the hospital. And so also the health policy companies will also not prefer going patients to non-NABH accredited hospitals. And then NMC has certain requirements for the college to be recognized. Recently, some things have been made. So all these actually required at least all of them require a different need. Some required a breastfeeding room. Some require there should be some creche, because you are employing so many women. So there should be some place where the mothers can breastfeed. And then they also need the training of the staff. So these things are required under different heads, NAAC, NAM, and NMC. So it was easy to discuss with the hospital administration and also the university administration that this is the requirement. Our university have been accredited by NAC, and also the hospitals NABH accredited. So it was a little easier to discuss with them. And generally the private setup, they try to follow generally all these bodies which ultimately monitor the institutions. The another advantage is there's a one window clearance for all the decisions. There's no need to go this file to that way, talk to that person, this person, like a government system. So just a decision taken at one place. So that's the biggest advantage, that you can get the things done immediately. Again, once the things have been decided, that the flow of money is also is hassle free. There's nothing to be, this place, that place, and then a file has to be go to this account office, and then ultimately to additional MS, and then to MS, and blah blah. All these things are not there. Money comes hassle free. So again, the time is saved. Once the decision has been taken. And unlike government system, the money is not jammed or time bound. You have to spend within this time. Otherwise, you have to again take the re-evaluation of this. So it's not there. Then implementation, if agreed, is quick and easy, because we are not going to have a tender or this and that or that. You just want to do the things, do it immediately. So there's again no issues. Although purchase department is there, like you have to buy, you want to purchase, say, pump. So it will not take much time. It's so quick, easily can you do it. Then staff cooperation is assured, because unlike the government system, it's very difficult to take an action against anybody. But in a private sector, this problem is not there. You can always, the management can always call them and ask them, why are you not doing it? Why are you not performing? So generally, tendency is there, the staff follows your instructions. There's another thing there, some of them may not agree with you, but they will not put any obstacle. So things will be done, and it is easy. The another problem which we face, all of us face, is the manpower. Who will ultimately be counselor is not in that much of supply. Then you can have counselor, and then you have lactation counselor, and then other manpower available in OPD and an IPD and an ICU, and also OBG ICU. So and antenatal clinics. And then we have also have ART centers. You need a counselor there also. So we thought, why not intern and postgraduate students can fill up this shortage, because they ultimately also need treatment. Now, medical colleges, what I use this word is medical colleges are not for treating patient. So this ultimately I was able to impress upon the Vice Chancellor as well as my Chancellor and so the management people that medical colleges are there how to treat the patient. That is our job. So our responsibility are different. We have to generate evidence. We have to follow because the student once goes out, all the medical colleges are producing doctors and they will be practicing for 40 years, 45 years in the market. So we have to develop in them a self-learning capacity and skills so that they can continue to, the things are changing very fast. Knowledge is expanding. So interns and postgraduates, student build up and we took this initiative. Then we found that recently the National Medical Commission has come out with the competency-based medical curriculum, which requires certain skills to be generated and few skills have to be mastered by the undergraduate. Otherwise, he cannot appear in the examination. So there's known as certifiable skills. Unfortunately, the pediatric curriculum does not have any certifiable skill in infant feeding, neither breastfeeding nor complementary feeding nor other general nutrition. So we have decided in our IAP IVCF chapter and also discussed with the NMC people because we are in touch with the NMC people because we have got a lot of IT-based tools for medical education. So that this lacuna need to be looked into and some of these skills should be certifiable so that every intern and every undergraduate masters it. So that is the points with some of these terms. Can I have the next slide? There are certain barriers and these barriers need to be again tackled. Like convincing the management is difficult as there is no compulsion on them. So we have to find out the reason why you want to do that. Simply saying that because this is not a government mandate in any case to have baby-friendly hospital or breastfeeding-friendly hospital. If that kind of a circular comes, it will be very easy for all the medical colleges at least they will have it. So you need to, I could use the NABH, NACC, and then the NMC the guidelines somehow to make them comfortable. Another barrier is training of all the pediatric and OBG staff is a Herculean task. It needs extra efforts because the undergraduates, the interns are a moving population. They go, next batch comes. We need people who are there. They are actually nurses. At least one thing has been done that they are not transferred out of the OBG or pediatrics. They go to one other ward. In that, we have trained everybody, so there's no problem once they go from Med 1 to Med 2. There's no problem because they're already there. But all the nurses need training. And then they have to be taken out of the job and do the training. So that's something have to look into. We have trained about 18 nurses. BPNI has trained our people there. But we have got much more than them posted in NICU, PICU, and everywhere. I am thinking to actually sensitize all the clinical department because children go there also. For example, otitis media, they go to ENT department. Some other surgical problem, they go to surgery and other departments. And we need all of them to be at par so that they not switch over to any other kind of feeding. Then another thing is the management shows a reservation of spending money on the training of all these staff. So that's actually, they say, what is the minimum requirement? 18-month training of these people. So they say, okay, but then all the people, all the nurses, it becomes a little difficult for them. So we have to understand on that part and what can we do. I thought that let there be in-house trainers available. Then probably this problem can be tackled. Now for them, we have to have a TOT. So if we have every medical college, hospital has a TOT, or maybe 2 or 3 institutions in the same city, if they can have some trainers available, then this problem of training the people will be taken care of. Now, for organizing a TOT, you need some support because it requires 4 trainers will come, and then they're all stay and then transport, TA, and those things require money, and also we need to have. So I'm talking to the local UNICEF of UP government. We were in touch with them, and Sushma, you actually NNF organized the facility-based newborn care regional in Lucknow. So that time the Mr. Srivastav came from UNICEF. So I discussed with him that if he can help us at UP level. So recently I am in touch with one UNICEF person. Actually, she is helping the UP government in tackling the web problem, vaccine avoidance behavior families. So they have collaborated with us, and only today our team has gone to these community. I've also visited that area which is having problem and not accepting immunization. So I am trying to hold the finger and then ultimately going to end the hand so that some money comes so that we can have the trainers place in Lucknow only, so that we can train other people also without charging money and all that, and then probably we'll be able to do that. So these are some of the barriers where I could feel I was in a little envious position, being the dean and being in close contact with the administration. I could get the things done easily, except the training of all the people and spending money on that. Rest of the things they were able to help us. They are also giving pump, electric pump too. They have agreed, and they have already order has been placed. And very shortly, maybe 15 days or so, we were actually busy with breastfeeding World Breastfeeding Week celebrations on a very large scale, and then we go to BPNI for our accreditation. Thank you very much.
Thank you, sir. Thank you.
Yeah.
Thank you, Dr. Faridi. Now I would like to invite questions from the participants. If there are any, you may raise your hand or put your questions in the question answer box. Some of the questions were answered in the question answer box by the experts.
Yeah, I think there's a Neeta
A
Rani
question by
raised a
Neeta
hand.
Rani. Yes.
Go ahead, Neeta Rani. Yeah. Please unmute Neeta Rani. Go ahead. I think maybe,
It is by
yeah.
They are
Maybe
unable
she-
to mute probably.
No, she might have left or whatever, Yeah, she raised her hand, so we allowed her, but anyway.
If there are any questions,
I put a question in the question box or in the probably chat box to Sushma.
Anji, sir.
What?
Not in the chat.
My question was that you presented very nicely and statistics supported by this. Wonderful. My question is, how many of these women who use a mom or took the support from the milk bank were able to exclusively breastfeed once they were discharged, and for how long?
So as a part of the project, when we had somebody who could track them, we did that for 1 year, and they were tracked for 6 months. मतलब 1 साल तक वो करते रहे, but each mother who got discharged from the NICU, sorry, each baby who got discharged, so we track them. So the first policy is that we don't discharge them on spoon feeding. We try and ensure that the baby latches onto the breast and the baby is directly feeding at the breast when they are going home, unless if the family has some issue and they feel that enough is enough, now we have to go home, it's already 8 weeks, 10 weeks in the hospital. तो but शुरू से मैसेज क्लियर ये रहता है कि जब तक छाती से दूध नहीं पिएगा बच्चा, छुट्टी नहीं होगी. छुट्टी होने का वो प्री रिक्विजिट है. सो जो फॉलो किया गया था उसमें 57% वर एक्सक्लूसिवली ब्रेस्ट फीडिंग till 6 months of age. There were many on mixed feeding, in fact, and we could not track. About 8% of them were not reachable क्योंकि ये phone से ही, this was a tele counseling and tele communication. मतलब she was calling by phone and following them up. So
Right.
this was, but we could not continue with that all through because we require one person who is just doing this. So जब हमारे पास में ऐसी support थी, so that time we could do it. But obviously it is not 100%, sir.
Thank you, Dr. Sushma. There's a question for Colonel Shaw from Neha Divedi. She's saying that, sir, you mentioned that you have LCs in the RR hospital. Any information on how they are employed?
Unmute, Subhash, you need
Unmute.
to unmute.
I'm so sorry. We have lactation counselor with us right now. So, yeah, is he asking about vacancy or I didn't
Yeah,
understand?
I think the question
Okay.
relates to that.
Yes.
How do you employ? Looks
Okay,
like.
fine. In case someone is interested, can meet me. But right now we have our lactation counselor.
I think she is asking for the process of employment as a
Employment,
counselor,
yeah.
not only in your hospital, but
But
in
for the
any army
Yeah.
hospital.
So what most of our hospitals have done, sir, we have trained our own staff, the nursing officers,
Exactly.
our
Okay.
own, and that has helped
Maybe.
us the maximum because it is their own hospital, and things have improved drastically.
So they have designated as counselors, right?
Yes.
Is that
Yes.
right?
Yes.
Okay, that's a good thing,
But
sustainable
we
also.
have also done with our
Yeah, yeah.
nurses only, and they
Makes
are the
sense.
ones who are doing, because
I think
getting
this is a very good
counselors,
idea. Very good idea. Okay. So they are actually taking off the clinical care and
nice.
they are doing only
Nice, sir.
counseling.
Some of them are doing, those who are in the NICU,
Both.
they are doing both work, but some who are with the CLMC, they are not doing the NICU work for the time being. There are some 4-5 questions, Nupur, for you.
Yes, yes. Yes, Soumya, please go ahead. Rima, can you unmute Soumya? Yeah, Soumya, please go ahead with your question.
Thank you everyone for amazing presentations. I wanted to ask, since our panelists are mostly a lot of implementation work has already been done. I wanted to know, like Dr. Shaw presented about EIBF. So basically, although NFHS says that the rates, like it is quoting the rates to be much higher, but some independent studies also say that in some poor performing districts in UP, it goes as low as 15%. And the problem that I see with like even if it's tertiary care hospital or community hospitals, PHCs and CHCs. So the problem comes when the birth happens, the mother is considered to be the OBGYN responsibility, whereas the baby becomes the pediatrician's responsibility. And that's how the mother and baby end up getting separated. So in terms of protocols, what are the things which you like? I would want to hear in different facilities. I request for that. How are we bridging this gap in each of the facilities? If you can share some insights.
Who is going to take it? So Shushma, if you can take that question, yeah.
I'm actually at Jim's Noida, Greater Noida. So there was a talk here, and then I thought I was not from here only. So there was some disturbance, and I was telling them, "Thoda chup rahiye, kyunki bahut chal raha hai." I couldn't listen to her question fully.
Okay, she's asking that if there is a division of labor here between the obstetrician and the pediatrician. The baby belongs to the pediatrician and the obstetrician. This whole thing has been going on. I've been listening since ages of my life. So it continues.
And I mean, baby belongs to pediatrics or neonatology, that is fine. But there are people both sides which are going to the maternity ward, and they are looking after the mother as well as the baby. We hope that the obstetricians talk to the mother about breastfeeding, but often that does not happen. So then our counterpart who is going in the postnatal ward is actually focusing on the baby's assessment and the breastfeeding assessment.
Are there any specific, protocols which are describing this process? Because that is one piece that I see missing in most of the facilities. Like there are independent protocols, but not protocols which sort of merge the roles and responsibilities of both the departments and see it from a perspective of putting the dyad mother baby together. So in that sense, like if there are any.
Can I?
Sir,
Can I come in? Soumya, the way to go if you want to bring a change in this is to follow the steps rather than the departments. So if you follow the 10 steps and the whole unit is responsible, then if you monitor the data as suggested by Nupur in the tools, I was going to say during my talk in the end about way forward. So one of the point which I want to insist as well as guide is that you just follow each step. Somebody has to be responsible for that rather than saying is the pediatrician or gynecologist responsible. So it might be a nurse, it might be the counselor, it might be obstetrician or a pediatrician, whosoever it is. So the protocol can be seen only in the 10 steps, right? So it will be very hard. Otherwise, this pediatric gynae thing has never stopped in our life. And I don't think it will ever stop also, because we have the habit of putting the onus of responsibility on somebody else when we can't perform. So yeah, yes, Sushma, you want to add? Yeah.
No, so I just wanted to say that we have to accept the fact that pediatricians will go once, maybe twice in the postnatal ward, look at the baby and come back. But eventually it is the obstetric side nurse who is taking care of mother and baby. And if the baby happens to have any issue, she is the one who's rushing the baby to the nursery or calling a pediatrician. So it's like a teamwork. You can't really compartmentalize that this is this one's job and this is this one's job.
I totally agree. That's
And
where
I would
the policy,
like,
that's where the policy
Shah has
helps.
also raised his hand.
Yes.
I'd like to add here further that see both of them, the responsibility are different. One is looking after, both can't look both at a time. One is looking after one like mother, the other is looking after the baby, because not only just breastfeeding, several other things he has to look into. So also the obstetrician. But goal ultimately comes here that, as we rightly said by Arun, that the 10 steps we follow will be able to ultimately help this woman and this baby to feed. So I don't think that there's anything wrong in it, that a pediatrician basically responsible for newborn and obstetrician responsible for the mother. Yes, they are responsible. They have to look after. Their expertise is different. Problems are different. But one goal is here that let this baby get the nutrition from the mother only, and in the process, mother is also benefited. So that means it's the interest of both of us, of pediatricians as well as obstetricians.
Yes.
Colonel
Yes.
Shaw,
Yeah.
please, you may go ahead. Yeah.
Yes, so I'll also tell the same thing, that one should not compartmentalize. Actually, it's everybody's responsibility. Why even doctors and nurses, even ward sahika, whosoever is there, everybody should be on board, and everybody should feel like helping the mother who is, first time mother or whatever. So it is everyone's responsibility, and I don't see any reason to compartmentalize the two things.
Okay.
And secondly, lactation counselor, dedicated lactation counselor is the answer in case it is like the number is too huge and not manageable by the obstetric nurses. So a dedicated lactation counselor will help a lot. In
Very
that
good.
One thing I like to add here, just quick comment, that I have not come across any obstetrician or a pediatrician who could feed her baby exclusively for 6 months. So if we are not able to do with ourselves, I don't think it will be possible to do with anybody else. I can share with you that my daughter is an obstetrician, OBG, and she had problem with the first baby, but insisted. Her mother was also insisting to give formula once, said no, and ultimately she could feed for 2.5 years. And the second, my grandchild also could get the breastfeeding accordingly. So I think this is possible.
So my son is exclusively breastfed, not a drop of any other milk, water, or whatever. So I have done what I talk about or preach.
It's possible, both sides. The cultures have taken years and 50 to 100 years to change things. So when I was born in 51, my mother never fed me on anything else. When my children were born in 79 and 81, my mother insisted that we both have to go to work. It's necessary that we give formula. So the point is that this whole thing changed during that period, and since then, I think the 60s and 70s, which brought formula to India, that period has not yet left us. So it might take another many years where we can't reach 100%, but we can certainly reach, at least in the hospitals, where we can, as I appreciate the Shaw's slide, which clearly shows the gap and why it goes into the next day. Why can't be the first hour, which we are all competent of, actually. So,
Absolutely.
yeah, if there are any other questions, Nupur? Yeah.
Yes, I'm just looking. This actually reminds me of my experience also. I recently came across my birth certificate, and I was born in 87 in a government hospital in R.K. Puram. And I saw there was a comment written on it that breastfeeding on demand. on my birth certificate. Like my mother breastfed me and she was fortunate to have a crèche also at her workplace. She took me along with her and used to feed in between breaks. So it was a classic case. So, but I was happy to see that slip.
That's why
More
you are
questions?
May
that's
I
why you are so intelligent.
may I request Nupur, may I request
Yes.
all the people who want to ask questions, please write your questions in the Q&A. So
Yeah,
for
there
the
are.
purpose we
There
can
are.
finish in time, so that
Okay.
otherwise when we
Yes,
talk,
we have
generates lot of.
we
Yeah,
have
please.
15 more minutes. There's a question from Renuka M for Colonel Shaw. It says, does Command Hospital Bangalore have human milk bank? You're muted, sir.
Yeah,
Yes.
as far as my information goes, probably they're in the process of having it. I'm not too sure, but Command Hospital Pune has it. That I know. Other hospitals are likely to get it, I said.
Okay.
So if there are no
Okay.
questions, can I
No
just
one.
say something to Dr. Faridi and Dr. Arun Gupta?
I have
that-
to round up first.
Acha. Acha, sir. No, my only thing was workplace may we don't have anything to support mothers who are lactating, whether it is an ayah or a
I
nurse or a doctor or anybody. So I think there should be some movement to say that
policy.
we should have a place where the mother can express or feed her baby if the baby can be brought in. So koi aisi jagah to honi chahiye. It is not there. Matlab, sorry to say that even at Lady Harding we don't have.
Yeah, I agree with you on that. This has been
Policy
going on
matter.
with the maternity issues several times on the maternity benefit policies. And unfortunate part is that this area is not a high priority area within the child health and the nutrition domain. So let's see, we continue to fight for the rights of women and children. And if I may now, Nupur, what is the status?
Yes, just one. We'll take just one last. Okay, we don't have any more questions.
Okay.
These are just
All right.
comments, sir.
So
Over
with
to you.
yes, I have the duty to thank you all first and giving your time and enlightening us as well as the audience today for closing the World Breastfeeding Week, the Close the Gap. One of the key areas which you all have mentioned, I just picked up the few important points and talking about from there, how do we go beyond? We are all excited for the World Breastfeeding Week. We all spend a lot of time on it. We give lectures, we do baby shows and whatnots, and we do everything possible to make a social movement out of World Breastfeeding Week. And I remember, we started this first World Breastfeeding Week was 1992. And the first theme of the 92 was also BFHI, right? So it's like the history is repeating. So we are still very short of where we were too. So that's why I think I thought of speaking a few minutes on the beyond part of it. Taking the areas from, for example, like Dr. Tank of FOGSI raised this very important point. There is so much actually on the mind of a mother. So not to undermine her confidence, prepare her well during pregnancy. That's something very key with then the not enough milk story, which he shared, is an important area of counseling and skill building and confidence building. So unless we have somebody in the hospital to be by the mother, it will be very hard for her to actually pursue if she wanted to breastfeed. Then we have Dr. Sushma. Actually, you raised a very important point of differentiating between the whole donor human milk versus mother's own milk, which is very, very important and critical to understand. Even I would say, I might be taken wrong about our pursuance of human milk banking. Actually is taking us somewhere away from the MOM side. This banking is excitement too. The banking actually easy to get money for, but I don't see any money for like what in the end Sushma said, and when a counselor may be appointed, a full-time counselor may be appointed. It's not very expensive. We did the calculation once, submitted to government, but so far it has not happened. But banks are coming up very sharply. I love that idea of CLMC at a very high level, tertiary care level. It should be the end point rather than at every place we are hoping to get. And now we are in a kind of a race also, which I think there is something which we need to rethink and re-strategize, all of us together, that how do we actually see that, does every maternity hospital deserve a human milk bank? No, it doesn't. It deserves a mother's own milk bank with a refrigerator where she can go express her milk, keep it there, feed the babies if they are in an ICU or a small baby somewhere, which I love that idea of MOM being more and more out in the public domain. Then we have Colonel Shaw. I think the discipline in the army hospitals and the following the policy and in a very discreet manner, I think is what is getting the success, and also the decision taken by the DGFMS on getting the hospitals accreditation. Now, this is beyond World Breastfeeding Week. This is something which I think we all should aspire, that all the hospitals where women come and give birth should aspire to be breastfeeding friendly, not because it's done by BPNI. And there could be another agency also. We would appreciate every state has a BPNI which accreditates, but there has to be interest from the hospitals who want to be. We have assessors in almost every state now, but the interest I'm not seeing much from the hospitals, particularly the private hospitals. And we noted down what Preeti said, that there could be a circular from the department, because none of the programs of the government currently, whether it is CLMC or it is MA program, actually reaches out to the private sector. So that's a gap actually in the policy and the program. So that's something which is beyond today. We need to work around. I'll meet. I'm planning to meet Dr. Vinod Paul tomorrow evening, and I'll take up this issue with him in terms of how this area can be. This is a gap in itself, that private sector is not at all covered by any program related to breastfeeding. They're not obliged to, actually. They may or may not do anything, but there are some of them, like 30 hospitals, more than 30 hospitals are now accredited. Half of them are private. That was their own interest. They went in, they came forward. Nupur shared the tools. I think they are very useful. BPNI has been working hard on them for years together. And we are now in times of completion, that this year we have completed them. All the tools are very helpful, very useful, available freely for usage, other than training part and all where the human resource time is required. BPNI does charge, and the accreditation process, we do charge for that to be sustainable. Now, to be sustainable for breastfeeding also, the accreditation process helps you because it is for 3 years. And you will also have to do, if there is a staff change or something, you will need to look into that area continuously because you want to get your certificate renewed also. So BPNI will continue to reach out to, and Dr. Faridi's area, which I mentioned earlier also, and I know that you are in a position to motivate people in the institution, but not all the medical colleges can. So can we, this is a question to you as well as Sushma, and if there is a possibility of, creating a group of the medical colleges, especially the private medical colleges, if we can reach out to them in a special conference, maybe online first, and if the resources permitted, we could do a conference, physical conference, which Lady Harding could host. And I'm sure it won't be difficult for you to raise funds for that. So BPNI is without fund for last 6 months now. We are on a zero funding. We are unable to raise funds. This is something unfortunate, but that's a struggle BPNI faces. That's why I'm making this request to you, being in the government sector, and the government might even agree with the objective to reach out to private sector. The MA program we could take to them, the MOM program we take to the private sector, accreditation we could take to the private sector. So these are the three objectives which comes to my mind, that if we can host a meeting of the obstetricians, pediatricians, nurses, whosoever wishes to attend that. If nothing, then we can do online, that we could host a meeting. BPNI would be very happy to provide the support which needed. So I would like to work closely with you on this in terms of reaching out to medical colleges in this country. They can be the examples for, smaller hospitals, that this is a possibility, this is a reasonable possibility, and the progress is possible. That is also understand. There is a possibility. Globally, in 2012, the global breastfeeding rate, exclusive breastfeeding rate was 38%. So we have been working globally on the World Breastfeeding Trends Initiative with WHO and UNICEF, and a lot of efforts, not just WBTI, but many efforts. It has gone up to 48% now. So the progress is possible. ऐसा नहीं है कि ये हो नहीं सकता है. The only thing is that if the government doesn't take initiatives, probably lack of staff, lack of time, lack of enthusiasm, there are so many things. Maybe we can, as long as we are able to, or before we retire. This is something which we can, this partnership can grow. I'm sure FOGSI would be very keen to join this partnership. I've been in touch with Dr. Tank, who is unable to join for the whole meeting today because he had a parallel meeting going on. But he has shown interest in terms of antenatal education program, which we have. So, and army hospitals have already joined this partnership. In any case, most of them have applied for the accreditation. We are working closely with them, and practices are very good. And Dr. Farid, there is one more thing which I'll share with you on the training part when we meet. And then I'll end that army hospitals have taken the load of training on themselves, right? So that's another area we need to discuss. How do we decentralize this action in terms of where the human resource availability may not be that required? And we can discuss this more when we discuss the future actions. So with that, I'll end again with my profuse thanks to you all, and all the participants who have spent their time and joined us for this webinar. And we are hoping to finish it in time. And before that, if there is any additional comment by the panelists, please go ahead. And thank you once again.
Is there, which I used in UP, and also the government and the private medical colleges, they all ultimately agreed for helping out the immunization program. See, there are 14 objectives of postgraduate training. If written under the NMC, there are 14 total objectives. Objective number 9 talks about that all the postgraduate students must take part in the national health programs of their discipline. So MA program is a national program. So therefore, this program comes under the heading, and for that, they can be for the training. This is ultimately for training. So we have to actually have this kind of, so we can have a meeting and say that this is already required. This is the part of the training of the objectives of the PG training. So if something of that kind done, and online training, as you have already done in a few cases, if that is being done, and then practical training can be done at the local level, then probably the cost will decrease of the training, and that may be bearable at that level.
Okay. Any other comment by the panelists? If you have any comment, or we can then over to Nupur to.
There's one question from
Yes.
someone. We'll just take that up and then finish it off.
Yes.
If you can, Hanan. Yeah, please unmute yourself. We have some international participants also with us. Yes, Hanan, you can go ahead. Please unmute yourself. Rima, can you unmute her?
Country Hanan is from?
Maybe
I'm
she can put
assuming
the
she's
question
an
on chat box.
international participant.
If she
You
can
can
write,
write your question in the chat box, Hanan.
From
I
Indonesia
think there
or
is some
from
issue.
Afghanistan?
There's some problem, I think. Okay, never mind. You can write the question in the chat box. Maybe we can address it later. So I would thank everyone, all our esteemed panelists for joining us and our participants for joining us in great strength. We had around 115 participants across India, though around 300 of them registered. But I'm sure people would be happy to have the recording of it, and we'll be bombarded with, request of giving recordings.
Actually,
Thank you.
there are not many programs today at the same time.
Yeah.
Yes,
That was also
because
evident.
it's the last day. Yes,
I-
yes.
Yeah,
one
I'm
more,
also sitting somewhere else.
At
where
the
I
same
have a
time, one
job
more
and
is
now
going
I'm
on with
thinking-
Kesavalu
And
and
actually,
other
ma'am,
people.
I am in touch with sir from gyms. We did a breastfeeding promotion program here once, long time back. So I sent an invite to him also. He's also an ex-army person.
Yeah, so
Rakesh
he
is
was
there, na?
worried. He was
Rakesh.
worried कि आप
Yes,
दोनों कैसे
Dr.
कर सकते
Rakesh.
Rakesh is, and we are from the same alma mater. He is junior to me.
Oh, yeah. So gyms could be the next hospital which can
Brigadier
become
Rakesh.
breastfeeding friendly.
Sure.
Yes. So thank you everyone for agreeing to be our panelist, and it was a very informative and educational webinar, and I hope that we get more enrollments for BFHI and more interest for becoming breastfeeding friendly after this webinar. Thank you very much, and thank you to all the
Thank you so much.
participants.
Thank you, everybody. Thank you, Nupur. Thank you.
Thank you,
You're
everyone.
welcome. Thank
Thank you,
you.
Dr. Arun, and thank you.
Thank you.
Thank you, Nupur.
Thank you, Colonel Shaw. Thank you, Dr. Sushma.
bye.
Thank you, bye.
Bye. क्या सवाल है? Okay, somebody is asking, Manish Taneja, how can we organize BPNI training in our institution? You can write to us, Manish, and you can write to us directly on the email address I'm sending you right now. And we can, the